Me to come and visit with you today about aligning the static and dynamic lower extremity orthosis from design to outcome. I'd like to first start off by having a quick review of some terminology so that we're all on the same page. When we talk about biomechanics, we talk about the branch of science that studies the structure and function of the body. When we talk about ground reaction forces, it's a force exerted by the ground that's equal and opposite in direction to a force being exerted on the object. When we talk about ground reaction force, it's the result of two or more ground reaction forces. And we need to start looking at these forces in three dimensions and not just in one or two planes, because the patient experiences these forces in all three planes: the sagittal plane, which is the anterior posterior axis, the coronal plane, which is the medial lateral axis, and the transverse plane, which is the vertical axis. When we talk about kinetic chain, we talk about a combination of several joints uniting successive limb segments. And then we talk about the kinetic chain in an open and an enclosed environment. The open chain being when the distal segment of the chain moves in space, or for ambulation, swing phase. And in the closed chain, the distal segment is fixed on the ground with the proximal parts moving over it, or stance phase. When we talk about passive range of motion, the angular movement applied to a joint by another person can be tested, but sometimes that's not the functional range of motion. The functional range of motion is the angular movement of a joint caused by the subject's applied muscle force, and it may be limited due to spasticity, contracture, or bony abnormality. Another thing we need to consider is the Tardieu scale, the R1 and the R2 values when we measure range of motion, the R1 being that initial end range or first catch, the functional range during physical activity, and the R2 range being the maximum passive end range with torque applied, typically not by the patient, but by their caretaker. When we talk about a vertical alignment line, it's a simple vertical line. The alignment of two random points in a plane by a vertical line or a plumb line typically is what I'm referring to. When I talk about shank to vertical angle, the angle of the shank as it relates to the vertical, and there's some discrepancies there when people are measuring, and sometimes when we're talking, we don't all speak the same language. So I think it's important to know what we're talking about. For example, Elaine Owens in the UK uses the anterior crest of the tibia. I think it's more common practice in the US to use midline of the leg, and that's what I use. But what should the standard be? Because when you write a paper and you read specific angles and try to correlate them to an orthotic alignment, if we're not speaking the same language, we're not talking about the same alignment. The next is the primary patterning, or the patterning of the limb during weight bearing, and then the secondary patterning, or the patterning of the limb during the swing phase. And then compensatory patterns are patterns that are caused by abnormal hip and trunk movements that the patient initiates, trying to overcome typically a primary patterning. When I talk about internal rotary pattern, I'm talking about a pattern when the foot is on the ground and weight is being applied, and the calcaneus goes into inversion, the midfoot collapses, and the forefoot abducts. When I'm out in the community talking to referral sources and therapists and other orthotists, commonly it's referred to as pronation. Some people refer to it as the patient being toed out, or the patient being externally rotated, or the patient being in valgus. And when I talk about external rotary pattern, it typically describes the calcaneus being in an inverted position with the midfoot being high or in a cavus position, and the forefoot being in adduction. But a lot of times I hear out in the community that the foot is supinated, that the patient is toed in, the patient is internally rotated, or the patient is in varus. And I think it's really important to understand what's happening in all three planes with these patterns and what we can do about it. When I'm talking about casting the patient, I typically cast my patients using a casting block. The casting block represents the height of the shoe's heel and any additional necessary height to accommodate a plantar flexion contracture. Also taking into consideration where I want to place the shank in space in inclination or reclination. The AFO footwear combination is also important to take into consideration, specifically the heel sole differential being the difference between the thickness in the heel and the thickness of the sole at the ball of the foot. And the slide below represents a fixed AFO being placed in different shoes with different heel heights, and you can see how it changes the alignment of the shank from reclination to a neutral alignment to an inclined alignment, just as if we were using different shoes on a prosthesis. The same alignment principles apply. And now let's talk a little bit about some biomechanical principles and the importance of these biomechanical and kinetic principles in your orthotic design. The assessment of the point and stance or swing that a problem occurs will influence your choice of your orthotic design. The open kinetic chain problems require much less rigid devices because you're simply trying to control a limb during swing phase. However, your closed kinetic chain problems must be able to resist the triplanar forces that occur from the ground up through the subtalar joint, the talocrural joint, the knee joint, hip, pelvis, trunk, and head under full weight bearing. So your closed chain kinetic problems typically need to be addressed by more rigid designs. So let's start off with our patient evaluation. I typically try to get a history that includes the primary diagnosis. What are we dealing with? Is it a stroke, a spinal cord injury, CMT, post-polio nerve injury, spina bifida, CP? Number one, you want to determine whether it's progressive or not, because that might affect the design that you treat the patient with now, trying to predict what will happen in the future. And then also trying to find out if the patient has any cognitive impairments that might prevent them from understand what we're trying to do now. The secondary diagnosis typically is some of the things that they present with, whether it be muscle weakness or ligament laxity, skeletal malalignment, amputation, and things like that. And then we move on to the tertiary diagnosis, which is really what we're managing as an orthotist. Do they have a foot drop? Does the patient have poor balance? What gait abnormalities do they have? Do they have pain? Typically want to try to find out what kind of devices that they've had in the past. It's really very important to try to determine that if they're a long-term patient, because they've been through several different clinicians, possibly several different devices, and they're really frustrated and trying to find out what's the best thing for them and what is new that they might be able to explore. And also additionally, what are their goals? We need to try to determine that so that we can design an orthosis to try to help them meet those goals. Some of their goals might to be stand and balance hands-free, walk with or without an assisted device, to walk hands-free. Does the patient want to be able to run? Are they just trying to reduce pain? Are they trying to prevent surgery or amputation? Then as we get more into our evaluation, when we start to evaluate ranges of motion, here's where you really begin to define the angular parameters of what your orthotic design will entail. I always say you can't cheat a contracture and obtain a normal functional alignment. For example, if you overly dorsiflex a person's ankle, you might be limiting knee flexion because of the fact that the gastroc crosses the knee joint. So just some things that you may want to consider when managing contractures. It's not just about the range of motion at a specific joint, but it might be the range of motion at a specific joint in a specific alignment. For example, the dorsiflexion at the ankle might be neutral if the knee is bent, but it might be 10 degrees of plantar flexion if the knee is straight. So those are things you need to consider. And then how can I achieve a more normal lever arm profile while working with the existing skeletal malalignment? And we can talk a little bit about that as we move on. When we start to do our manual muscle testing, this is really where you begin to define the necessary lever arm profiles of your orthosis. So, for example, if you have a weak plantar flexor, that's going to affect the toe lever mechanism within your orthotic design. So we need to consider, toe levers, heel levers. Are we going to make this device solid ankle? Are we going to articulate the ankle? Is an articulation appropriate? Are we going to allow an articulated ankle with free motion, but the patient doesn't have enough strength to overcome body weight in that direction? Are we going to make it dynamic, or a free knee or a locked knee? A lot of those types of decisions can be made during the manual muscle testing portion of your evaluation. And then we move on to our observational gait analysis. Visual observational gait analysis really is a little deficient. The eye frames at about 1,000 frames per second, but we really only process about 150 or 10% of the information that we're seeing. I like to take a video of my patient so that I can slow it down and really see what's going on. And I think when you're able to slow things down, this is where you're able to define the primary or weight-bearing patterns and the secondary swing phase patterns, as well as some compensatory patterns. So then I like to say, let's try to design an orthosis for all 8 phases of gait and not just for, portions of the gait cycle. Maybe we're going to address more than just the foot drop for swing phase. And I think to be able to design an orthosis for 8 phases of gait, we have to understand all of the things that I've touched on. Biomechanics, the structure, what's going on, kinematics, the motions of the body and what should be happening at what point in time, the kinetics, the forces that are applied to the body through the musculoskeletal system, or the forces that we need to apply to the body through orthotic design. What is normal gait? What is pathological gait, and what are the differences between pathological gait deviation and compensatory gait deviation? And it can be tricky. I've actually designed a brace to control a compensatory gait pattern. And what did I do? I made my patient worse because I actually braced them into the position that they were trying to get out of. And then I think we need to understand the goals and methods of energy conservation and efficiency. And to be able to do that, we have to obviously, what I just talked about, get a really good clinical evaluation, which I call clues to solving the puzzle. Each patient is a different puzzle, and they all have different pieces. And with good physical assessment, range of motion, manual muscle testing, gait analysis, video gait analysis, you should be able to come up in your mind with what your orthotic design will be so that you can pre-plan for your optimal cast. Once again, the primary control is designing strategies for weight bearing. And this is where you really need to consider the materials that your brace is going to be made out of. Is it going to be plastic? Is it going to be metal? Is it going to be carbon fiber? What kind of carbon fiber is it going to be made out of? Is it going to be flexible? Is it going to be stiff? The secondary control mechanisms typically, like I said previously, are fairly easy because it's swing phase control. Where you can really get tricked is the compensatory control mechanisms. And once you're able to demonstrate to the patient that they've learned compensatory control mechanisms and brace them appropriately, they're going to have to go for retraining after you've made that brace. And then part of that training is the energy conservation, keeping the center of mass moving forward with the smallest amount of deviation possible. And then functionally, how can they get from point A to point B safely? And typically patients are going to say the faster, the better. So here's breaking it down even further for the stance phase portions of the gait. What is your weight bearing alignment? We talked a little bit about cheating a contracture. You can't cheat a contracture. So what if you have to make an AFO that's plantar flexed 15 degrees? How do you overcome that in your design? And then understanding the difference between the functional range of motion or the passive range of motion, specifically in your spastic patients, because like I said earlier, if you over dorsiflex your patient, you might be limiting knee extension. So you're actually causing a problem. So where is it that we cast these patients? And that's an entirely different talk. But what I'm doing is I'm evaluating my patient with my knee fully extended and I'm getting my dorsiflexion power and row. That's going to be my functional limitation. And then I'm also documenting my R2, which is my end range. And typically where I'm trying to cast my patients is about my R2 range plus about 5 degrees. And even though that's not the functional R1 range, typically that's going to be somewhere in between there, which gives you a little bit of fudge factor so that you can start to help that patient get into better alignment and potentially stretch that contracture. You also have to understand that single limb stance stability, which is your primary control, is under full weight bearing. And to do that, you have to balance the center of mass over your support, which additionally creates stride symmetry. The one thing that's very, very difficult is the skeletal control and full weight bearing, and being able to design your orthosis with appropriate materials and appropriate control mechanisms to actually control that. And then as we look at as the patient is walking over the orthotic side, or it might even be bilateral, can you create the big V or symmetry so that when they're in terminal stance on one side, they're in terminal swing on the other? And will your orthotic design allow them to achieve a good pre-swing, which allows them to advance through the swing phase at appropriate position and time? Uh, and then the fairly easy portion is the swing, which is the secondary patterning. The foot must clear the ground. And then also the foot must be pre-positioned so that it's ready to accept weight on the next cycle. And then the way that I define running is with the patient walking faster and faster and faster, and then eventually running. In a true run, both feet will actually be off the ground. Um, so now we're kind of moving on to the casting stage. I think it's super important to understand that when we take a cast, we don't just take a cast, we're taking a cast for a specific reason. We're trying to control that primary position when the patient has weight on their limb. And so if your patient has an IRP pattern, the casting technique is going to be different than if they have an ERP pattern, because the control mechanisms are opposite. And you don't want to just take a cast and not know what you're doing, because if you're trying to control IRP and you actually cast them in IRP, you haven't done your job. Typically, when I'm trying to cast somebody for an IRP, I'm casting them in a little bit of ERP, and just the opposite. We need to understand, are we casting to try to reduce pain? Is there a specific range of motion that they're pain tolerant to? And what are the limits of that? What does my orthotic design have to limit to reduce them from getting to that point where they have pain? Am I trying to realign something in the transverse plane or the coronal plane, not just plantar flexion, dorsiflexion, that will allow them to have relief from that pain? Am I trying to offload them? What can I do in my casting technique to get a better mold so that I have a better opportunity to offload? And then we also need to consider when a patient's had an amputation of a leg or a foot, or have a leg length discrepancy, what do I need to do in my orthotic design to try to reestablish that lever arm profile as compared to possibly their contralateral side, which might be normal. Now let's talk a little bit about optimal alignment. So normal closed chain alignment of the skeletal segments starting from distal to proximal in all three planes under full weight bearing is very difficult to achieve, and I just said that previously. Now, as orthotists, we have to throw in our patients have muscle weakness, muscle contracture, poor balance, poor timing. Excuse me. They may have cognitive issues. And then some people start to say, well, am I a magician or am I an orthotist? But I think if you approach things in a systematic way and you break things down and you learn how to control those specific motions within your orthosis, that it's possible. So one of the things that I start to look at when I'm looking at what is my optimal alignment and within their goals is, most people's goal is to be able to balance. So static standing balance is achieved when the center of mass is balanced over the base of support. And for most people, that goal of balance means that they want to be able to try and do it hands free. So what we need to remember is, just like in prosthetic alignment, an orthosis has a vertical alignment line or a normal static TKA line, which is not the vertical, but very similar to what a prosthesis would be. So the vertical line will fall anterior to the ankle, anterior to the knee, posterior to the hip, and through the center of mass. And the one thing that I want to point out is when you stand in a normal static standing posture, you must have normal range of motion, strength of both the anterior tibialis and the gastroc complex, or orthotic intervention combined with some compensatory movement patterns to maintain this posture. For example, if you don't have normal gastroc strength, you cannot stand in normal standing posture. And then when we talk about reducing energy consumption, we all know that pathologic gait is tremendously inefficient. normalizing pathologic lever arms with a better orthosis and focusing on pathological and compensatory movement patterns in physical therapy can improve gait function, symmetry, and energy efficiency if you've designed the correct orthosis. Um, Improving gait function, symmetry, and energy efficiency will improve the patient's quality of life and result in better clinical outcomes. So now we're going to kind of break it down into some questions that I really think need to be answered. I think I have some of these answers, but I think we also have a lot of questions, and I would really like if people would start to delve into this. So when we talk about orthotic alignment, what are our goals? First of all, what is normal alignment? And then you have to ask yourself, is normal alignment the same as orthotic alignment? And then you have to ask yourself the question, is orthotic alignment the same as prosthetic alignment? And in some respects, they're the same, and in some respects, I think they're different. And in some respects, I think that orthotic alignment is different than what I would consider normal alignment. Because you have to realize we're fighting gravity all the way, and we can actually use the ground reaction forces to counteract the abnormal movement patterns that we see in our patients if we know how to align them in an orthotic alignment that might be slightly different than normal alignment. And then we need to start asking ourselves how much segmental deviation within the orthosis is acceptable. For example, when you're continually having to make adjustments to the navicular or medial malleolus within an orthosis, are we really controlling that pronation or that internal rotary pattern within the brace? Why do we keep pushing it out? Why is it not holding them? Have we really done our job? And then how much deviation of the orthosis under full weight bearing is acceptable? When you put a patient in a plastic ground reaction AFO and the ankle flexes, is that acceptable? And how much flexion in that orthosis is acceptable? We just need to start asking ourselves that. So what is basic or standard bench alignment? We know what it is in prosthetics because we were taught that. You know, you have your, let's talk about a BK prosthesis. You have your socket and you have parameters to measure from the MTP down to the floor and put the foot in relationship to the knee so that you have a basic starting alignment. You know, we typically don't think of orthotics that way, but I think it's very similar. And I'll show you a slide here in a little bit to explain that. And then we need to ask ourselves, does this alignment change to accommodate the patient's profile? So in orthotics, does our standard alignment change to accommodate the patient's profile? And I think it does. And then we need to ask ourselves the question, does this alignment change with the type of materials that we choose? And I think it does. And then we have to ask ourselves, does this alignment change due to manufacturer or fabrication specifications? And I think it does. So now we've just said that bench alignment is different from prosthetics to orthotics, or it's similar. However, it does change when we change materials, just as it would in a prosthesis when you compare, say, a Satch foot to a dynamic response foot. Will your alignment be the same? And my contention is it's different. So I love to talk about this slide. So when we talk about basic or standard orthotic alignment, does it mimic prosthetic alignment? So if you can envision a BK socket over the foot, we would measure from the MTP. And so what I want to point out in this slide is that the bright blue line, the horizontal line at the top, would represent the MTP location in your prosthetic socket. However, I want to point out additionally, the purple line below that is typically the height that we would cast a standard AFO. And so that piece of information that we would use in prosthetics is missing from our orthotic cast. The next thing I want to point out to you is that the red line is just a simple vertical plumb line. And then I want to point out the green line, which is the angular measurement off the tibial crest that I mentioned earlier when I talked about how, say, Elaine Owens measures in the UK. And then the dark blue line is the center line in the sagittal and the coronal of what the midline of the leg would be. And I want to show you the difference on the left slide, that the midline angle for shank angle is different from midline to the crest. And so if Elaine is telling you to put an AFO, say in 13 degrees of tibial inclination, if you were to measure the way we measure in the US and put that blue line at 13 degrees, you would end up in a lot more inclination than what Elaine had intended in her paper. So I think it's very important to note that how we measure matters and that sometimes we don't all speak the same language. Additionally, if you look at the vertical line on the right slide, it's different than the midline dark blue. So if the dark blue was set vertical because we missed the knee joint center or the MTP proximally in our cast, you could see that you would set the patient's knee in a valgus position by placing the midline vertical. Now let's talk a little bit about the casting procedures. Um, I think there's a lot of different casting methods. Some are based on the design of the orthosis. Some methods are designed for corrective. Some are designed for accommodative designs. Some methods are non-weight bearing. Some methods are weight bearing. And then I think sometimes we make a choice based on what materials we're going to make our brace out of as to how we cast our patient. And then sometimes we cast our patient in certain ways based on the brand specific products that we're going to use. And there's a variety of techniques that people use. Some of them have one stage. You just start at the top or start at the bottom and do the whole thing in one and try to hold everything together. Or you might do a 2, 3, 4, 5 stage cast. I typically do staged castings. So I typically cast my foot below the subtalar joint, and then I will incorporate my ankle joint, and then I will cast above my knee so that I get that very important information that I just showed you in the last slide. Even if I'm not doing a PTB AFO, it helps me to set my shank in an appropriate sagittal and coronal alignment. The other thing that doing segmental casting allows you to do is as you're working your way up in your cast, you're correcting alignments, you're aligning them and balancing them. And I typically do my casting semi-weight bearing or full weight bearing, almost never non-weight bearing. So you can see on the left, this patient has a pretty severe ERP on the right and a less significant ERP on the left. But as I segmentally casted her, I corrected her in all three planes from the subtalar joint, then through the talocrural joint, and then up above the knee joint. And I think you can see on the far right that the alignment has improved from the bottom left uncasted picture to the top right casted picture. And then once I've got my casts taken, I spend a lot of time correcting my cast, trying to obtain an optimal alignment. And these are just some of the corrections that I do. And it's just an example of how we evaluate our cast. So forefoot varus or valgus. So in this slide, I've actually dropped the first metatarsal to get rid of that forefoot varus. In the second slide, I've corrected out hindfoot varus or valgus at the subtalar joint. The middle slide represents, I didn't use my casting block to accommodate the heel sole differential. So if I was to actually dorsiflex or plantar flex right here into my desired angle, once I put it in the shoe, I would end up in an odd shank inclination angle. So then we move across to accommodate the heel height, and then I'm able to measure my inclination angle. And then finally, the last one represents my corrected shank angle while accommodating the heel sole differential. Once we have our brace made, we do the fitting, and fitting equals function. So the first thing to look at is the device alignment in the shoe. Skeletal alignment, both non-weight bearing and weight bearing, have your patient stand up. Are you truly controlling the deviations that you want to control? And then we move on to functional alignment, both non-weight bearing and weight bearing, alignment dynamically, and then follow up. And we'll talk a little bit about those. So in our static fitting, have we designed the trim lines to achieve triplanar control of the foot and ankle? Have we done our trim lines to create rigid or flexible toes? Have we included wedging to create an alignment that provides hip and knee extension or hip and knee flexion? The AFO footwear combination should provide static standing balance at this point. Once you've done your trim lines and everything and had the patient stand, the goal right at this point is static standing balance and hands free if possible. And then we move on to our fitting. So where do we start? I just said static standing balance needs to be achieved before you start to dynamically tune the orthotic system. So here's what we're looking for. Do I have a heel first initial contact? I want to try to minimize the knee flexion moment at loading response. I don't want to try to eliminate it because knee flexion at loading response is normal. However, if you're working with a patient, let's say on a free knee KAFO that has 0 quads, you can't initiate a knee flexion moment or they'll buckle. So that's a thing that you have to understand when you're designing your orthosis, is that maybe I don't want that in this design, and that's okay. This is just a basic tuning guide. You know, do you have an inclined shank and a vertical thigh at mid stance? And then in terminal stance, is the thigh inclined as well? Do you get hip and knee flexion at pre-swing? Do you get hip and knee flexion at initial swing and then through the swing phase? And then do you actually get knee extension and terminal swing so that you're set up for that heel first contact again? So as we start to clinically observe the patient's gait pattern now, things that we can do to continue tuning are raise or lower the heel wedge to optimize what we call the shank kinematics, how it's moving through space. We're looking for an inclined shank and vertical thigh at mid stance and an inclined thigh in terminal stance. But how fast did it get there? Is it uncomfortable for the patient? Can I slow it down by changing the density of the wedge or the height of the wedge? Additional things that you can do are modify shoe rocker profiles. You know, can I undercut the heel or can I undercut the toe, or do I need to actually extend the toe and make a positive rocker on the front? And those types of things. And I want to note that this alignment methodology works for any type of lower extremity orthosis. It just depends on, is the orthosis designed with materials that are appropriate. So if the patient has enough muscle strength to perform the task, you don't need as much strength as if they don't. But if you design an orthosis that doesn't have enough rigidity that the patient's normal muscle strength would have provided, you're going to end up with compensations or an abnormality. And so really what you're trying to do in the tuning process is to define your heel lever arm length, your toe lever arm length. You can, do wedges on the inside or wedges on the outside to address medial and lateral, both forefoot and hindfoot lever arms. You can address toe out sometimes, based on the density, it will either increase or decrease some of the rotation, but some of that comes from the hip as well. And then I just want to note the materials will also change your bench alignment. So the stiffer or the more flexible the material you're going to design your orthosis out of will change your bench alignment. Just like I said previously, it's just like aligning a prosthesis with a satch or a dynamic response foot. The socket placement is going to be different, just like your shank inclination will be different in an orthotic design. So the features that are tunable when we're dynamically aligning are the heel wedges. Sometimes the toe stiffness is adjustable if it's a plastic design. If not, you're looking at either remaking your device or changing the rollover with rockers on shoes. And those rockers, you can do positive or negative heels, point loaders, they can be curved. There's a variety of things you can do to try to tune the kinematics of your orthotic design. When we talk about problem solving, when you don't like what you see, where do you start? So maybe we don't have heel contact at initial contact. Maybe we have forefoot contact. What might be the cause of that? Well, if you're dealing with a patient that has spasticity, it might be lack of hamstring range of motion. So they swing their leg out there, they hit that R1 in the hamstrings, and the toe hits the ground. Well, did did we pre-plan for that? Did we know that was going to happen? Maybe we can't affect that, but it's just something to look at. Or is it lack of gastroc length and you've over dorsiflexed them so the gastroc is hitting that R1 because you've got them in, 5 degrees of dorsiflexion at the ankle when maybe they needed to be in 10 degrees of plantar flexion at the ankle so that they could get that last 10 degrees of knee extension. And the dynamic tone patients are really difficult. It's much, much easier when you're dealing with a flaccid patient. Rapid knee flexion at loading response might be because the heel lever is too long. And what causes a long heel lever? Either the shoe is too hard, or the heel wedge is too hard, or there's too high of a heel. You've artificially lengthened the heel lever arm in your orthotic design, and you made the heel lever arm too long. Um, a reclined shank might mean that you don't have enough heel wedge, or the patient changed shoes. Reclined thigh at terminal stance might be that you don't have enough heel wedge to get them up and over into an inclined, or that the toe lever arm is too flexible to stop the knee and the thigh can't catch up. So there's just things you have to evaluate about your orthotic design to try to problem solve. Not enough knee flexion at pre-swing might be that the toe lever is too stiff and you're just holding that knee into extension. Or it might be in a typical, stroke patient that they've got dynamic tone in their quads and they're just not going to get knee flexion. Um, maybe you can't overcome that deviation. And then lack of knee and hip flexion during swing might be from dynamic tone. Typically in a flail patient, as long as they're stable through the gait cycle and they can break over the toe and get into pre-swing, they're going to have hip and knee flexion. Now I'd like to just show you some possible outcomes of some patients that I've had the opportunity to manage. There's different designs, different pathologies. I tried to pick a smorgasbord. Um, But I want you to think about each one of these patients as an individual case, and how do we define a good outcome? How is their balance? How is their stability? How is their speed? Have we improved their gait, their posture, their functional tasks? Have we been able to improve the quality of their physical therapy? So this first lady is a CMT patient. Here on the left, she's unbraced. She's walking down the parallel bars and holding on with her right hand. She obviously has a steppage gait. She has a crouched gait. She has a very difficult time standing and balancing hands free. She doesn't like to, or she won't. I had the opportunity to make her a dynamic bracing solutions, ground reaction, dynamic response AFO. Uh, there we go. Sorry about that. So you can see that her foot drop is controlled. She's now getting knee extension from mid to terminal stance where she didn't in an unbraced condition. She does have hip flexion contractures, but she will start to stretch that out. And if you notice, she's able to stand and balance hands free in the hallway before she even gets started. So we achieved her goals of static standing balance, improved posture, improved stability, improved speed, just by looking at, triplanar management and the alignment of her orthosis and designing her an orthosis that had the correct stability or rigidity. So here's a partial foot, or a show part amputee that I had the opportunity to make a partial foot for. Um, you can see that he walked into the office with no device, very unbalanced, very safe, very unsafe. And I had the opportunity to make him a partial foot dynamic prosthesis, or ground reaction AFO, whatever you want to call it. It's got the PDE strut on there. Basically, we aligned it just like we would an orthosis or a prosthesis. And then he's able to use the dynamic response uh, to achieve a much more stable. He's faster. He can stand and balance hands free. So I think that's a pretty good outcome as well. This is a stroke patient that I had the opportunity to see. I'm going to show you the unbraced, and then what they were managing the physical therapy with was a toe off, and then I was able to make them just a solid laminated ground reaction AFO that was aligned and tuned. So you can see in the unbraced condition, still very weak. He has tone. He actually has internal rotary patterning and stance and external rotary patterning and swing. He has lack of knee extension in terminal stance, walks in a crouch. They tried to manage him with the toe off, and he just didn't feel stable. It still didn't control the rotary problems at the foot and ankle. And then I was able to fit him with the laminated solid ground reaction AFO. He still has difficulties controlling internal rotation and external rotation at the hip. But if you compare no brace to toe off brace to the stability that we were able to provide on the right side, you can see his gait speed has dramatically improved, and that's on day one. This was an MS patient that I got the opportunity to work with. Here in the unbraced condition, she does have a foot drop. She's got weak plantar flexors. She does pop back into knee hyperextension, but she also has a difficult time initiating pre-swing and swing. Um, I was able to fit her in a laminated ground reaction AFO with the posterior dynamic element. Um, you can see here on the right, she's just testing it out at first, trying to figure out where she's stable, how to get her hip to track straight over her knee. And that's some of the things that your patients will experience when they start to deal with a brace that now is stable, that they can actually shift their weight over, is they're trying to figure out how can I stay stable while I actually shift my weight. And she really needs to go to PT. You got to remember this is just day one of the fitting. This is another patient I had the opportunity to work with. He's a left BK, right partial foot. So he has a partial foot similar to the one that I showed you previously. He actually laid in bed trying to heal his wounds for about a year. And when he finally got healed, we were able to get him up. And in about a month after we started the fitting process, he was actually able to go back to work. And this is him at a 2-week follow-up. Just picked his cane right up and he's walking in a happy camper. This man had a tumor resection. He has a fused first toe. He's in a lot of foot and ankle pain. He doesn't have very much range of motion at the ankle. And he came into us basically because he wanted to walk better and try to eliminate or reduce his pain. So you can see he walks very gingerly. He doesn't really roll through his foot. And we were able to make him a laminated ground reaction AFO with the posterior dynamic element strut. We aligned it in space, reestablished normal alignment through a little bit of wedging. There, I think he's doing pretty good. This is a young man they had the opportunity to manage who had CP. He's got right-sided hemiparesis. He does have weak plantar flexors, weak dorsiflexors, walks in a crouched gait, on the right side. Uh, he walks pretty fast, but we were trying to improve his kinematics, so we were able to fit him in a, a polypropylene strut with the Coyote, or a polypropylene ground reaction AFO with the Coyote strut, similar to this AFO on the right. And here he is. You can see as he rolls through right at terminal stance, he actually gets knee extension, even running, where he doesn't in walking. This was another young man I had the opportunity to work with who had cerebral palsy and right-sided hemiparesis as well. He has a significant internal rotary pattern at the foot and ankle. Um, it is somewhat correctable, but not fully. But you can notice, even you can see his knee internally rotate, which is the internal rotary component on top of the subtalar and talocrural joints, and then obviously his foot's just collapsing medially. So we were able to fit him with a dynamic bracing solutions brace, really corrected him in the triplanar at the foot and ankle. And now you can see his toe is pretty much straight ahead now, in line with the knee joint. And he was able to show us that he could run as well. This man has a spinal cord injury secondary to gunshot wound. He's actually a sheriff. You can see that he's pretty much completely flail from the knees down. His bilateral foot drop. He does have bilateral IRP in stance and ERP in swing. And we managed him in a dynamic bracing solutions AFO. This was day one. He's just learning how to get his weight shifted over out and out over the toe for stability and actually get a knee extending during stance instead of a knee flexing during stance. He does need gait training and learn how to walk more with his hips and shift his weight, but he was able to stand and balance hands free, which he was not able to do without the orthotic intervention. And his speed has improved and his confidence has improved. And I think he has a lot more improvement yet to come. It's another spinal cord injury patient. Very similar presentation, pretty much completely flail below the knee. He does have weakness above the knee as well. He is not able to stand and balance hands free. I was able to fit him with a dynamic ground reaction AFO, which is shown on the right with the posterior dynamic element strut. You can see on day one, skate pattern is improved. I have changed the wedging in his shoes since then, but even on day one, you can see in the video on the right, he didn't really move much, but he lifted up his walker and said, I can stand hands free. And I think that was a success for him on day one, and he's continued to improve since then. This is a young man. He's one of four young folks in the US to get the polio virus from the live vaccine. Some of you may have seen him in my talks before. I like to show him as he's growing and has improved. Um, that left leg is 2.5 inches shorter than the right leg, and his right foot size is a 14, and the left is about a 9. So he's about 5 sizes difference in size. He obviously has IRP or internal rotary patterning at the foot, ankle, and knee. He's completely flail from the knee down. He does have some quad with limited glutes. So I was able to manage him in a dynamic bracing solutions KAFO, similar to the one shown here. That's not his brace. Um, but you can see we were able to smooth out his symmetry by reestablishing his leg lengths. Actually, he's on a 2.5-inch heel wedge within that shoe. His heel is basically sitting outside of the shoe. And obviously, we've controlled his triplanar deformity at the foot and ankle and knee and got everything aligned so that it tracks straight and true. And then with the improved alignment and stability of the brace, he's actually able to run. And I challenge anybody to show me that with a polypropylene KAFO. So I think that's a great observation of what can happen when you realign and establish alignments with your orthotic design, provide appropriate materials, and just do a good job. So I want to thank you for the opportunity to having been able to present to you today. Feel free to contact me if you have any questions, and I look forward to your questions. Have a great day.